So we will talk about updates in the management of EGFR mutation lung cancer. But before going into this update, we should know something about the molecular pathways and the profiling of advanced lung cancer, non-small cell lung cancer. This is the kind of slide that I always look at when I used to present, whether in lung or breast. It represents not only the evolution of medicine, but also it represents where we were, where we stand before, and where are we today. So we thought 15 and 20 years ago that we are treating lung cancer. In fact, we are treating at that time a single disease entity. However, with time, we found that lung cancer, as breast cancer, is also a heterogeneous disease entity. So we started with non-small cell lung cancer because it comprised around 85% of all cases, while small cell is representing only 10 to 15% of patients. And if you go to the histological breakdown, it's almost 15 years ago where they discovered EGFR mutation. And when they discovered EGFR mutation, they did not look at it as a mutation per se, but they look at it as one of the predictive biomarker, because as we will see later on, there are a lot of drugs that predict when there is a sensitizing EGFR mutation, it will predict actually the response to treatment. So after EGFR, many years later, we have the story of ALK. And again, ALK rearrangement, we have a lot of drugs that targeted this particular rearrangement. And then we have ROS1. And of course, we have a lot of targetable, actionable mutations in lung cancer. And then the most important advancement in medicine and in lung cancer is about immunotherapy. So in order to talk about immunotherapy and the response that we get with immunotherapy, because not all the patients are getting a good and a significant actually response with immunotherapy. In fact, some of the patients are getting a lot of adverse events and side effects from immunotherapy. So they should have actually discovered a targetable biomarker in order to say that this patient might get a response to immunotherapy. So they looked at, first of all, PD-L1 expression. And this is by far the most important biomarker that they can study. And they looked at it by immunohistochemistry. So when they looked at it, then they looked at the percentage of PD-L1 expression, because they thought that the higher the percentage, the more likelihood is the response to immunotherapy. However, with PD-L1 expression, there are a lot of limitations, including the testing platform that has not been standardized yet. And then they looked at another predictive biomarker, which is called a tumor mutational burden, TMB. Now with TMB, they looked at the number of somatic mutations in the codon of a tumor itself. So they think that the higher the number of the somatic mutation, then the more is the likelihood of getting a response in immunotherapy. So this is the overview of where we are right now in the management of lung cancer. Now, the 2021 paradigm for immunotherapy in advanced non-small cell lung cancer without an actionable mutation. That's to say, for our dearest young oncologist colleagues, whenever you face a patient with adenocarcinoma of the lung, don't think of this patient as being treated with chemotherapy right away. The issue is we have to send this patient for EGFR, ALK, as well as PD-L1 expression. Because if the PD-L1 is low or it's negative, that's to say less than 1%, then the standard of care could be still an immune checkpoint inhibitor plus chemotherapy. And if it is in the range of 1 to 49%, then definitely, or more than 50%, then definitely the choice will be single agent immune checkpoint inhibitor. And we know that in May 22, 2020, Nivo-Ipi was approved for the first-line treatment of advanced non-small cell lung cancer with more than or equal to 1% PD-L1, and Nivo-Ipilimumab plus 2 cycles of a platinum doublet chemotherapy approved for the first-line treatment of advanced non-small cell lung cancer without EGFR or ALK genomic aberrations. So that is without any actionable mutation. And this is by far the most important slide that we have to look at it, because 50% of patients with advanced non-squamous, non-small cell lung cancer will have a driver mutation, that we should think of it and we should search for it. So these are actionable mutations that are targetable with an FDA-approved drugs. So it's not a single disease entity as we thought 15 or 20 years ago. So we have EGFR sensitizing mutation that happened in around 17%. We have the KRAS in 25%. We have the ALK rearrangement in 7%. We have again MET mutation. We have the BRAF mutation. We have the HER2 and the ROS1. And all these are actually targetable, whether we have an FDA approved or we have a new drug or a new molecule in the pipeline for the future research. And if you think of the treatment paradigm in the presence of such actionable mutation, one would say where chemotherapy would fit into the management of this patient if we are going to use an actionable, targetable medicine for this particular patient. So it's very nicely presented here. We have a first-line treatment and we have a second-line treatment. So if the patient is having an EGFR mutation, then definitely we have to look at all these drugs. Of course, osimertinib now is the preferred, but we can go for erlotinib, gefitinib, afatinib, or even dacomitinib. But whenever you first use and choose osimertinib, then whenever the patient will fail, you have to do a rebiopsy, because failure after erlotinib, it might be one of the mechanism of resistance, and it might be an EGFR T790 mutation. And once it's an EGFR T790 mutation, then you can target it again with osimertinib. The other issue is that if you use osimertinib in the first-line setting, then nothing will be left for you apart from chemotherapy. Now, the same holds true for ALK, because in ALK, we have right now 4 or 5 targetable drugs. We have alectinib, brigatinib, ceritinib, crizotinib, lorlatinib. So it depends on the sequence that you are going to use in the management of those patients. BRAF, the same issue, right? If failure for NTRK positive, entrectinib or larotrectinib, it failed, then you have to go to the second-line chemotherapy. So this is why I presented the molecular profiling, because every one of us should think of it in the right manner. So what about the management of those patients who are having actionable mutation, EGFR mutation, in the advanced non-small cell lung cancer. It facilitates targeted treatment? Yes, it facilitated. What about the acquired resistance in the first and second generation TKI? So whenever you have a failure of gefitinib or erlotinib, one should think that we have another important drug in order to target such a mutation. Do you have an acquired resistance to the third generation TKI? Yes, we do. And we will see later on what kind of resistant mechanism we will have to look at while using the third generation TKI. And early detection of a mutation is involved in the resistance may help further stratify treatment decision. So these are the drugs that we are talking about. We have the first generation, gefitinib, erlotinib, and these are called reversible TKIs. We have the second generation, afatinib and dacomitinib, and these are actually irreversible TKIs. And we have, most importantly, the third generation, osimertinib. Now, we know for years that the standard of care for those patients with metastatic non-small cell lung cancer was combination chemotherapy. So this is the first and the very important trial that was conducted in 2009, IPAS trial. And they looked in the IPAS trial in two important subgroup of patients. First of all, they took the East Asian population, those patients who are actually never smoked before or even light smokers. They have some of them having activating mutation in EGFR in the form of exon 19 deletion or a point mutation in exon 21, and they looked at gefitinib versus carbopaclitaxel, which is the standard of care in that time. And if you look well, that gefitinib in the green line achieved much better than carbopaclitaxel in terms of hazard ratio. Sorry. In terms of hazard ratio of 0.48, that's to say for progression or death. Thank you. And a very significant p-value. And they looked at the EGFR mutation negative. And in this particular case, you will see that carbopaclitaxel is doing much better than gefitinib. Most importantly, it's not only the progression-free survival. Once you have an EGFR mutation positive, you will think that this patient might have a 70% objective response rate as compared with 1% for the EGFR negative subgroup of patients. And then, 2 or 3 years later, another important TKI inhibitor, erlotinib, was investigated in 2 settings. First of all, in China, where they looked at erlotinib versus 4 cycles of gemcitabine carboplatin, and the results are very clear. We have a very prolonged median progression survival in the erlotinib group as compared with the gefitinib group, with the gemcitabine carboplatin group, 13.1 months versus 4.6 months. And then the ERTAC trial that was conducted in Europe, where they took the East Asian population as well, and they looked at the EGFR mutation in those patients, and it's very obvious that everything is going with erlotinib versus gemcitabine carboplatin. So far, we have 2 important first-generation TKI, erlotinib, and gefitinib, that they did well against the standard of care, which is chemotherapy. Now, the story is that they did not only look at the progression-free survival, but they took these important TKI and the safety as compared with combination chemotherapy. So if you look well for erlotinib, for example, and if you look at neutropenia, we have 0 neutropenia as compared to grade 3/4. 42% of patients on gemcitabine carboplatin are experiencing a very significant neutropenia that might actually kill the patient. And then they look at thrombocytopenia. Again, we have 0 event, while we have around 40% thrombocytopenia on the other group. If you look at anemia, infection, everything is going well, actually, except with the increase in the ALT. We have an increment in the ALT with the erlotinib, which is in the range of 4% for grade 3 and 1% for the chemotherapy group. So it's not only efficacious in prolonging survival of the patient, but also it showed that they are safe as well. And now, having said so, and preparing the scene from the first generation to the second generation, let us have a look at the story of the second generation. They said that if the first generation patients using first generation are doing well, what about the second generation? So they looked here in a very important head-to-head comparison between afatinib, gefitinib, as well as dacomitinib and gefitinib. And it's a very important trial, actually, because they looked at the median progression-free survival of both, and it seems that afatinib actually extended the median progression-free survival from 11.5 in the gefitinib group to 13.7, and again, a significant p-value. The same thing holds true. Dacomitinib did much better in terms of median progression-free survival as compared with gefitinib. So we have 2 important second-generation TKIs that they did well as in comparison with the first generation. And because they did well, you should have a look again at the safety of these drugs. So they did such very nice comparison between the two. Just have a look at dacomitinib in terms of diarrhea, only 8%. If you go to gefitinib, then you will find grade 3 only in the range of 1%. So it means that dacomitinib is causing much more diarrhea than gefitinib. The same thing for the dermatitis acneiforme, 14% in the dacomitinib group, while it's only 1% in the gefitinib group. What about afatinib? Then we have, again, diarrhea in the range of 12%, and we have rash or acne in the range of 9%. So they discovered that the first generation TKI was efficacious and a bit safer than chemotherapy, while the second generation is efficacious, but it caused much more toxicity than the first generation TKI. So we should look at those patients for acneiform rash, and we should search for those patients for diarrhea. And actually, I used to teach my patient and to educate them proactively that you can face this, and that. And then we have to look about the quality of life for those patients. And it's very obvious here that everything is going up in terms of the associated symptoms, fatigue, diarrhea, sore mouth, and the global quality of life with a very, very significant p-value. It means that not only efficacious and safe, but it improved actually the quality of life for those patients with metastatic EGFR mutant non-small cell lung cancer. Then they thought that when we added actually Avastin, bevacizumab, to chemotherapy in those patients, we extended survival for those patients for the first time to 12 months. Because the PFS for chemotherapy is in the range of 5 or 6 months or 4.5 months. So adding bevacizumab to chemo extended the PFS to 12 months. What about adding erlotinib to bevacizumab? Then it's very obvious. Adding erlotinib to bevacizumab extended the progression-free survival from 9.6 months in the erlotinib group alone to 16.4, with a hazard ratio for death or progression of 0.52 and a very significant p-value. So erlotinib and bevacizumab can be used together. And then they looked at overall survival. Unfortunately, we achieved nothing in terms of the combination, in terms of overall survival. And then they looked at PFS in modified intent to treat population. And again, the PFS seems to be extended by around 3 months when using the combination of erlotinib plus bevacizumab. And the final overall survival actually was numerically goes with the combination, but there is no statistical significance. And once again, adding ramucirumab to erlotinib extended progression-free survival. Now, they think that if we add gefitinib to carbopem, what will happen? Because carbopemtrixid is the standard of care for those patients with adenocarcinoma, metastatic adenocarcinoma. So when they added gefitinib to carbopemtrixid, and we have to look at two PFS, PFS1 and PFS2, then the Kaplan-Meier curve goes very well with the combination of gefitinib plus chemotherapy as compared to gefitinib alone. So after the first progression, no, it's almost the same.
No significant.
What about overall survival? Actually, it extended overall survival. So in this combination, overall survival correlates only with the first PFS. So the combination improved progression-free survival only. What about osimertinib? This is the most important story. This is the third-line TKI that inhibit not only sensitizing EGFR mutation, but also the resistant T790 mutation. So this drug is the third generation TKI. And when they took this drug, they looked again at the progression-free survival of gefitinib versus gefitinib carbopem, and we said that it's extended in the chemotherapy group, and then they looked at osimertinib against the standard TKI, which is either gefitinib or erlotinib. And very nicely shown here that those patients on the osimertinib group having a prolonged median progression-free survival of 18.9 months versus 10.2 months for the standard EGFR TKI. And if you look at those patients, then they took the subgroup analysis, and they looked at those patients with CNS metastasis while on osimertinib against the platinum pen, and they have a median progression-free survival of 8.5 months versus 4.2 months, while those patients in the intent to treat population, the whole generation, the whole patients, they have osimertinib 10.1 months against 4.4 months. So this is the FLORA study, osimertinib against the standard EGFR TKI, and it's very nicely represented here, an extended median progression-free survival of 18.9 months versus 10.2 months, while osimertinib here in the overall survival has not been calculated because the data was immature actually at the time of interim analysis. If you go to the CNS disease, again, osimertinib is doing much better than the standard TKI. It means that osimertinib is active in CNS disease. So we have achieved 15.2 months versus 9.6 months. If you go to those patients who have no metastasis, then 19.1 versus 10 it's almost the same. So it's active against in patient with CNS metastasis. What about the progression-free survival? It's very much extended here, but we have to look at every subgroup in this particular trial, because if you look well, every subgroup in this trial is actually benefiting and favoring osimertinib over the standard TKI, whether these were the age less than 60 or more than 65, whether their ECOG status was 1 or 2, whether we have Asian or non-Asian, whether they were smokers or non-smokers. So the third generation TKI proved to have an extended progression-free survival in all these patient subgroups. The overall survival has been also extended from 31.8 months to 38.6, and the hazard ratio actually 0.8 and a significant p-value. And then they looked at, again, most importantly, the safety of this drug. If you look well, diarrhea, rash, acne, nail effect, dry skin, paronychia, but just have a look at grade 3 over 4 toxicity, for example, in diarrhea. It's almost 1% versus 3% for the standard of care. So it's more efficacious, actually, and much more safe. So the impact to clinical practice is that osimertinib is the standard of care first-line treatment in the United States, better PFS, CNS penetration, and side effect profile. FLORA updated data further support this with overall survival benefit, and the EGFR TKI sequencing strategy is not supported. And the most important future questions: will vascular endothelial growth factor or chemotherapy added to osimertinib improve the outcome? So future studies will provide the data. So these are my last slide, final slide, the mechanisms of resistance. So when you use osimertinib, and then after 30 or 40 months of overall survival, you will have to look why this drug has failed, while it was actually protecting my patient for the last 40 or 50 months. Because these important mechanisms: acquired EGFR mutation, acquired amplification, acquired oncogenic effusion, whatever it is. But the most important, so whenever you have a patient on osimertinib, failed osimertinib after 30 or 40 months of overall survival, you have to do a rebiopsy again. Because the most important mechanism of resistance is a transformation into a small cell lung cancer, which might represent about 15% of patients. So instead of giving Gemzar carboplatin, you have to start again with etoposide, cisplatin, and so on. So you have to think of rebiopsy once again. Thank you very much.
Thank you. Thank you, Dr. Tahseen, for the nice presentation.